Hello guys, let's do some quick revision about some of the previous year questions asked for pediatrics in NEET PG and INI-CET exams. Okay, so first of all, pseudo paralysis. Okay, what you are seeing in this picture is frog-legged position. Okay, and this particular pseudo paralysis. Okay, this happens in case of scurvy. The answer is scurvy. Okay. Scurvy is caused by vitamin C deficiency. Okay. That is the answer. Pseudo paralysis, if you see, this is caused by vitamin C deficiency in cases of scurvy. Now, what is the reason behind this? The child has severe painful subperiosteal hemorrhages. Okay, and that is why there is voluntary immobilization of the limb in these cases because of the swollen and tender limbs. Okay, the child will cry on touching the limbs. Okay, so that's why it is called pseudo paralysis. It is not actual paralysis, and frog legged position is what the child takes. Okay, now next is selenium deficiency. What is selenium deficiency going to cause? Okay, it's going to cause Keshan disease. Okay, this is the answer. Keshan disease. What is this Keshan disease? Basically, there is congestive cardiomyopathy. Okay, congestive cardiomyopathy in this. Okay, and what is this patient going to have? First of all, selenium deficiency. Why does this occur? The soil is deficient in this mineral, and this happens in some areas in the world where the soil does not contain enough amount of selenium. Okay, now what are the things it is going to cause? It can cause arrhythmias. Okay, arrhythmias, it can cause, okay, cardiac failure, and this is a fatal cardiomyopathy. Okay, this can cause cardiac failure symptoms like pulmonary edema. Okay, it can cause enlarged heart. Okay, enlarged heart on the chest x-ray and echo imaging findings basically. Next, what is Wimberger ring sign? Okay, now again, this is seen in scurvy. Okay, now you have to remember this word over here, ring sign. Okay, ring sign. Why this is important? Because Wimberger sign, the other one, Wimberger corner sign, that is seen in syphilis. Okay, so this ring word is absolutely important. What happens, as you can see over here in this particular picture, this is a schematic diagram. Here this ring epiphysis basically means what? Okay, there is this zone of calcification, there is this ring of calcification. Okay, and this ring of calcification is basically because of increased density that encircles an osteoporotic epiphyseal center. So this epiphyseal center, this is surrounded by a dense calcification over here. Okay, this is the Wimberger sign. Now the second thing is, what is this white line of Frankel? Now just beneath the growth plate, okay, there is this white line of Frankel. This is also again due to increased density, okay, and slowed calcification at the edge of the metaphysis. Okay, and this is just beneath the growth plate, just beneath the growth plate, and this is also again a line of calcification. Okay, and this is called the white line of Frankel. Okay, now what is Pelkin's spur or Pelkin's fracture? Now this is triangular area or a small projection, okay, which extends from the margins of the metaphysis. Okay, it extends from the margins of the metaphysis, and it is caused by healing microfractures. Okay, healing microfractures and subperiosteal hemorrhage. Okay, so what are these three radiological signs? All three are individual questions for NEET. First is the Wimberger's ring sign. This is because of ring calcification around the osteoporotic epiphyseal center. Then there is white line of Frankel. Again, this is a radio-opaque zone at the end of long bones, and this is due to increased density and slowed calcification at the edge of the metaphysis just beneath the growth plate. And Pelkin's fracture, this is because of healing microfractures, and this is from the end of the long bones, small projections, triangular projections from the end of the long bones. Okay, all three are individual questions. Now windswept deformity, we all know that there is this particular typical textbook picture. Okay, there is one knee which is in the genu varum position, and there is one knee which is in the genu valgum position. Now how do you remember this? Okay, the simple way of remembering this is gum is going to stick things together, so it's going to stick the knees together. Okay, this is the feet of the child. Okay, sorry about that picture, I'm not very good at drawing. Okay, so this is genu valgum. Okay, these knees are sticking to each other. Okay, now what is genu varum? This is basically bow legs. Okay, genu varum is bow legs. Okay, so the easiest way to remember this is gum is going to stick the knees together, and varum is basically bow legs. Now windswept deformity occurs in rickets. Okay, phrinoderma. Now vitamin A deficiency. Okay, this is seen in vitamin A deficiency and essential fatty acid deficiency. This is a very typical picture, and this is an image based question. Okay, toad skin, like you saw in the previous picture also over here. Okay, this particular skin lesion resembles toad skin. Okay, again toad skin is seen in vitamin A deficiency. Growth failure or hypogonadism and anemia. Now these three things, okay, growth failure, hypogonadism and anemia, these are pointers towards zinc deficiency. Now growth failure and anemia may be seen in other deficiencies as well, but you have to, this has to ring a bell. Okay, hypogonadism, if it is given in the question, okay, it should point towards zinc deficiency. Right, what are the other things that zinc deficiency can cause? It can cause hair loss. Okay, it can cause diarrhea, persistent or recurrent diarrhea, or prolonged diarrhea, that takes longer to heal. Okay, then delayed wound healing. Okay, again this is a feature of zinc deficiency. And bullous lesions or blisters around orifices. Okay, orifices like around the lips. Okay, around the anus. Okay, blisters or bullae around the orifices, these are all features of zinc deficiency. Okay. Now what is this x-ray looking like? If you carefully look at this particular picture is suggestive of hyaline membrane disease. Now this, we all know that this occurs in preterm newborns. Okay, preterm newborns, and this occurs because of surfactant deficiency. Okay, surfactant deficiency. Okay, and this particular thing, this white out lung. Okay, white out lung is what you are looking at. White out ground glass. Again this should ring a bell. Ground glass appearance. Okay, ground glass appearance on the x-ray, appearance of lungs, ground glass opacities, this should ring a bell. Okay, all these white stuff that you are seeing in the lungs. Okay, this is all because of surfactant deficiency. Hyaline membrane disease is the other name for respiratory distress syndrome that occurs in preterm newborns. Right, and air bronchograms. Here what you are seeing here, if you see carefully over here, here, all these things are air bronchograms. Okay, again you may get a question on this. Right, and you have to identify what is it pointing at. So these are all air bronchograms. Okay, again that is a clue to this thing being hyaline membrane disease. Now bag and mask ventilation is contraindicated in diaphragmatic hernia. Now we all know that diaphragmatic hernia is basically the herniation of intestinal tissue into the thorax, right, because of a defect in the diaphragm. So now if you give bag and mask ventilation to a child who has CDH, what is that going to cause? Because of bag and mask ventilation, this is going to cause increased gaseous distension, okay, of the intestines in the thorax, okay, of the herniated segment, okay, herniated segment in thorax. And now what will happen is it will cause a mechanical pressure on this particular area, which is the heart and the lungs. Now the lungs are already, there is pulmonary hypoplasia, okay, and already the thorax and its contents are compromised, and then this gets distended, and that is going to cause mechanical pressure on the other organs, okay. So that's why bag and mask is contraindicated in CDH. Next, conjugated hyperbilirubinemia in infancy. What are the genetic causes? So first and the foremost thing you have to remember that Dubin-Johnson syndrome and Rotor syndrome. Okay, doctor. Johnson syndrome and Rotor syndrome. Now D for doctor and D for direct. Okay, so you remember this as a doctor. Doctor is DR, D for Dubin Johnson and R for Rotor syndrome. Okay, and doctor, D for doctor, D for direct. So remember this way, that it causes direct, or in other words, conjugated hyperbilirubinemia. Okay, it causes conjugated hyperbilirubinemia, and it's one of the congenital causes, and that we will discuss later why it causes these. So now again, Dubin-Johnson syndrome, okay, and Rotor syndrome. What is the primary difference in this? You should know the basics. Okay, now this Dubin-Johnson syndrome is basically impaired excretion. Okay, now impaired excretion into the bile, of the bilirubin into the bile, okay, whereas Rotor syndrome is impaired hepatocellular reuptake, okay, impaired hepatocellular reuptake of the bilirubin. So this you have to remember very clearly. Okay, one is DJS, Dubin-Johnson, which is impaired excretion into bile, and Rotor is impaired hepatocellular reuptake. Okay, and usually in Rotor syndrome you will have nearly 50% of the bilirubin, which is the conjugated bilirubin, and usually this is harmless. The other thing, DJS is a pigmented liver. So you will see that the liver may be black. So if the question says that the liver is pigmented or the liver was black, okay, it has to point towards Dubin-Johnson syndrome. If all the other things match conjugated hyperbilirubinemia in the question, if other things point towards conjugated bilirubin, okay, and in Rotor, the liver is normal. So this is one of the other differentiating features, and you should remember this, as this is important from the exam perspective. Unconjugated bilirubinemia, remember CNG, okay, for unconjugated hyperbilirubinemia. Okay, now what is G? G for Gilbert syndrome, okay, G for Gilbert syndrome. And CN is what? CN is Crigler-Najjar syndrome type 1 and 2. Now both of these are caused by mutation in the gene UGT1A1. Both of these are caused by mutation in this gene, okay, and UGT1A1, okay. Remember this for the MCQ part. Phototherapy reduces serum bilirubin by structural isomerization. Yes, that's the right answer. Now what does it do? We all know that unconjugated bilirubin, okay, this is lipid soluble, okay. Now if we want to excrete this in the urine, it has to become water soluble, okay, then it goes into the urine and gets excreted. Now what happens? Phototherapy, okay, phototherapy will convert this unconjugated bilirubin, okay, through photoisomerization, okay, photoisomerization into its water soluble form, which is lumirubin, okay, and lumirubin will be excreted in the urine, okay. The other thing is photooxidation. Photooxidation. Okay, photooxidation is the one, is the procedure by which this is converted, bilirubin is converted to colorless polar compounds. Okay, colorless polar compounds, and after that it is excreted in the urine. Okay, polar compounds. So these two things you have to remember: photoisomerization and photooxidation. In IDM, most common metabolic abnormality. Now we all know hypoglycemia can happen in infant of diabetic mother. Why is that? Because the mother has persistent high sugars in pregnancy, that causes hyperglycemia in the fetus, that causes increased insulin secretion. Now when the baby is born, okay, baby is born with that physiology, and now there is a likelihood of the um, sugar levels to drop in the newborn baby. So we all know why hypoglycemia occurs. Now what is the reason for hypocalcemia? Okay, now in the diabetic mother, gestational diabetes, okay, there is increased calcium levels, and calcium is passed on to the fetus. And now what happens, the fetus is now born, the newborn has functional hypoparathyroidism. Okay, functional hypoparathyroidism. Okay, because what happens, higher level of calcium is there in the blood. Okay, that causes reduced activity of the parathyroid hormone, and that causes functional hypoparathyroidism. The other thing is there is increased loss of magnesium. Okay, increased loss of magnesium because of glycosuria. Okay, and this again it causes reduced activity of PTH, and therefore reduced absorption of calcium, reduced absorption of calcium. Okay, so remember this, that in GDM the most common metabolic abnormality is hypoglycemia and hypocalcemia. Okay, because the fetus, once the baby is born, has functional hypoparathyroidism, which causes reduced absorption of calcium, as well as because of the negative feedback, the parathyroid hormone is not acting appropriately. Commonest congenital cyanotic heart disease, cyanotic, remember this, read the question carefully always. Okay, so cyanotic heart disease, commonest one is tetralogy of Fallot. Okay, tetralogy of Fallot. Now why it is tetralogy, we all know this. Okay, there is a ventricular septal defect. Okay, there is pulmonary infundibular, okay, stenosis. Okay, this aorta is directly lying over this VSD, so there is overriding of aorta. Okay, and then because there is this pulmonary infundibular stenosis, because of this there is a right ventricular outflow tract obstruction, right, because the pulmonary artery empties the right ventricle, right. So when it is stenosed, okay, so this is going to cause reduced right ventricular emptying, and there is pressure changes on the right ventricle, and that causes right ventricular hypertrophy. So you have to remember these four things: VSD, pulmonary infundibular stenosis, overriding of aorta, and right ventricular hypertrophy. Now Ebstein anomaly, now this is again an important question. Okay, this is caused due to intake of lithium. Okay, now what is the main problem or main anatomical abnormality in this Ebstein's anomaly? So we all know that the tricuspid valve has three leaflets, right? Three leaflets. So there is anterior leaflet, there is posterior, and there is septal. Now anterior leaflet becomes fenestrated. Okay, there will be fenestration changes in the anterior leaflet. Septal and posterior, they go and get kind of adhered to the myocardium. Okay, these two, septal and posterior, they become adherent to the myocardium. Now what you are seeing over here is the atrialization of the ventricle. Okay, and that will be a dilated right side of the heart, the right atrium as well as the right ventricle. Atrialization of this right side of the heart. Okay, and this annulus, the true annulus of this tricuspid valve, becomes low lying. It goes down into the right ventricle. Okay, so Ebstein's anomaly is associated with all these changes. Okay, downward displacement of the functional annulus. Okay, and dilatation of the right AV junction, the atrioventricular junction, which is basically the true tricuspid annulus. So remember that it is caused due to, Ebstein is caused due to lithium intake, and Ebstein, B, remember this B over here, that is seen as box shaped heart on X-ray. That is again a MCQ question. Okay, Ebstein. Remember the B in Ebstein. So B for box shaped heart is seen in the X-ray in Ebstein anomaly. Next is anatomical closure of ductus arteriosus by what day of life? So usually 12 to 24 hours mein what happens is there is a functional closure of the PDA once the newborn baby is born. Okay, functional closure of the PDA happens because of increased arterial oxygen tension. Okay, increased arterial oxygen tension, and there is drop in pulmonary vascular resistance after birth. So what happens is pulmonary vascular resistance drops and there is reduced blood flow through the ductus arteriosus. Okay, reduced blood flow through the ductus arteriosus. So these two things, one is increased arterial oxygen tension and second is reduced blood flow through the ductus arteriosus. Because of this there is functional closure in the first 12 to 24 hours, but within the next 2 to 3 weeks it closes anatomically because it kind of fibroses. Okay, anatomical closure. Okay, this happens in 2 to 3 weeks, but if your options are there, then you select the closest one, which is by day 10 of life. Okay, maternal SLE. Now maternal SLE, it is associated with passage of antibodies anti-Rho and anti-La. Okay, so this is SSA, SSB. Antibodies, these pass through the placenta, these go to the fetus. Now in the fetus it is going to cause inflammation and scarring. Okay, what's going to happen? Inflammation and scarring of the nodal tissue. Okay, of the AV node tissue. And what happens because of this? There will be conduction abnormalities, right? Conduction abnormalities are there because of this. Conduction abnormalities will happen because of this thing, and usually this pathology happens in 18 to 24 weeks of pregnancy, basically in the second trimester. Okay, so remember this also is a frequently asked question. Remember the names of the antibodies, anti-Rho and anti-La, and inflammation and scarring of the AV node that leads to congenital heart block and conduction abnormalities in the heart, fetal heart. Okay, now differential cyanosis. What is differential cyanosis? Okay, differential cyanosis is seen in which condition? Okay, first of all, this is seen in this is basically identified by cyanotic lower limbs only. Okay, cyanotic lower limbs only. Now what happens in reversal of PDA? Reversal of PDA means that initially PDA is basically a left to right shunt. We all know this. Okay, but in long standing untreated patent ductus arteriosus, what happens is there are vascular changes. There are changes in the vascular bed in the lungs. Okay, the pulmonary vasculature basically, and that can cause Eisenmengerization. Okay, so Eisenmenger syndrome. Now in Eisenmenger syndrome, what happens? There is reversal of shunt. Okay, that becomes right to left. Right to left means this deoxygenated blood. Okay, the deoxygenated blood is going from the right to the left side of the heart. Now that is going down through the aorta. Okay, okay, through the PDA, it will go into the aorta and it will cause cyanosis of the lower limbs. Okay, as you can see here, there is cyanosis and there is clubbing of the lower limbs more than the upper limbs. Now this differential cyanosis, where there is more clubbing and cyanosis of the lower limbs, that is the toes, more than that of the fingers, and this is a very pathognomic mnemonic sign for Eisenmenger syndrome, and this is caused by uncorrected PDA. Okay, what is reversal of differential cyanosis? Okay, reversal of differential cyanosis. Now you have to remember this: PDA, TGA with PDA, and coarctation of aorta. Okay, so basically in TGA what happens? This is the right ventricle, this is the left ventricle you are looking at. From the right ventricle you are going to, what arises from the right ventricle is the aorta, contrary to what happens normally. From the left ventricle what arises is the pulmonary artery, right? So there is this aorta, this vessel is carrying deoxygenated blood. This pulmonary artery is carrying oxygenated blood from this left side of heart into the lungs. Okay, now when there is a PDA, okay, PDA, so what happens is there is this connection between these two great vessels. Okay, now in reversal of differential cyanosis what happens is the upper limbs are cyanosed. Okay, upper limbs are cyanosed and the lower limbs are not cyanosed, or they are pink. There is reversal of this. Okay, so these are not cyanosed. Okay, now upper limb is cyanosed. Why is upper limb cyanosed? Because this left ventricle is pumping oxygenated blood into um the pulmonary artery, which is going to the lungs, but because of coarctation of aorta, this right ventricle is actually not able to empty the deoxygenated blood completely. This pulmonary artery, which is carrying the oxygenated blood through the PDA, through this connection, this pulmonary artery is actually going to push this oxygenated blood into the descending aorta. Okay, and the lower limbs receive the oxygenated blood and are not cyanosed. However, the upper limbs are cyanosed because they are receiving the deoxygenated blood predominantly, as that is going to the lungs and that is further going to the upper limbs and the arteries that supply the upper limbs, that is the subclavian artery. Egg on side appearance, egg on string appearance, this is seen in TGA. Now TGA is basically what? Transposition of great arteries. Now both the arteries, this is the cardiomegaly, this is enlarged chambers. Okay, this is egg on side appearance, and it appears like egg on string because both these main vessels, the aorta as well as the pulmonary artery, they stack on each other, and that looks like a egg on string appearance. Okay, what is snowman appearance? This is figure of 8 appearance. Okay, TAPVC, this is seen in total anomalous pulmonary venous connection, figure of 8 appearance. Remember this for MCQs. ASD with mitral stenosis, Lewton-Barker syndrome. What is Lewton-Barker syndrome? Basically left to right shunt at the atrial level. Okay, left to right shunt at the atrial level along with mitral stenosis. Now mitral stenosis, this is most of the times this is an acquired condition because of rheumatic fever. We all know that rheumatic fever can cause mitral stenosis. Okay, this is an acquired condition in rheumatic fever. Now what happens is because of this ASD, a large part of blood goes from the left atrium into the right. Okay, so there is very less gradient through the stenosed mitral valve. So in presence of a large ASD, if there is very little gradient, or if there is any lower gradient through this severe mitral stenosis, that still should be considered significant. Now, even balloon mitral valvotomy, okay, is actually considered as a component in the Lutembacher spectrum. Okay, so any left to right shunt at the atrial level along with the mitral stenosis is Lutembacher syndrome. Commonest congenital heart disease we know, that is VSD. VSD is in 25% of the cases of congenital heart disease, and along with, if you look at complex congenital heart diseases, then it mounts to around 50% cases. So it may be existing with other anomalies, other abnormalities of the heart in another 25%. So in total it can be even in up to 50%. Okay, so commonest congenital heart disease is VSD, and nearly 25 to 50% of the congenital heart disease may have VSD as one of the components. Syndromes with ASD, now this you will have to remember only. Okay, Holt-Oram syndrome, Down syndrome, Ellis-von-Creveld syndrome, Rubinstein-Thybe syndrome, thrombocytopenia absent radius syndrome, Peary-Robbins syndrome, Ehlers-Danlos syndrome, and fetal alcohol syndrome. Down syndrome, the commonest congenital heart disease is endocardial cushion defects. In this, atrioventricular canal defects, basically AV canal defects. Okay, this you have to remember. AV canal defect or endocardial cushion defects, these are the commonest cardiac congenital heart disease in the children with Down syndrome. Most common cause of stridor shortly after birth is laryngomalacia because of the floppy larynx. Okay, so floppy larynx, every time the child is breathing, the child will have this sound of stridor. The child may be otherwise well apart from the stridor. Most common cause of bacterial pneumonia in children is Streptococcus pneumonia. Okay, now this is what, this is gram positive, as you can see in this picture. This is again a picture based, image based question. Gram positive diplococci, which are lancet shaped, as you can see. Okay, lancet shaped diplococci, and you should remember that this is the most common cause of bacterial pneumonia in children. Okay, aerosolized ribavirin is used in the treatment of bronchiolitis with RSV. Okay, and the oral form of ribavirin, okay, that is utilized in the treatment of hepatitis C virus infection. Okay, the oral form of ribavirin is used for hepatitis C virus infection, chronic hepatitis C virus infection. What does it do? It basically interferes with the viral mRNA. Okay, it interferes with the viral mRNA, and it blocks, okay, it blocks the viral RNA dependent RNA polymerase. Okay, RNA dependent RNA polymerase, this is blocked by this drug, and it therefore helps control the multiplication of the virus. Okay, so this again you have to remember. This ribavirin is basically a synthetic nucleoside analog, and aerosolized version is used for the treatment of RSV, especially in immunocompromised hosts. Then, what is the most common organism associated with cystic fibrosis? Pseudomonas, we all know it is an opportunistic, okay, pathogen. It is an opportunistic pathogen, Pseudomonas. So you will see this in cases of cystic fibrosis, you will see in cases of burn wounds, you will see this as nosocomial infections, okay, and those with children with primary immunodeficiency. Okay, wherever there is opportunistic infections, or children who are immunosuppressed due to cancer and all malignancy. So Pseudomonas aeruginosa, it is the most common organism associated with cystic fibrosis. Okay, so cystic fibrosis, Pseudomonas aeruginosa. Remember that. Pneumatoceles after pneumonia. Okay, this again, this what you are seeing, this picture is again image based. You have to remember that Klebsiella pneumoniae and Staphylococcus, these two organisms can cause pneumatoceles after pneumonia. Commonest cause of intestinal obstruction in children is intussusception. What you are seeing here is the target sign. Okay, this is again an image based question. Okay, this is target sign. What you are seeing here, bowel within bowel appearance. Okay, over here also you can see this bowel, and there is another bowel telescoping into it. On a real time basis, you can see the bowel telescoping into the proximal bowel telescoping into the distal segment and reversing also. Okay, so this target sign you have to remember, and this is the commonest obstruction in cause of obstruction in children, intussusception. Skip granulomatous lesions are seen in Crohn disease. Now Crohn disease and ulcerative colitis, these two are inflammatory bowel disease. We all know that. Crohn's disease, okay, these are skip lesions. You don't see a continuous involvement like you see in over here in ulcerative colitis. Here in Crohn's disease you see fissure, fistula formation, and there are skip lesions over here. Okay, there may be transmural involvement, okay, throughout the wall, and these are the common findings: fissure, fistula formation, strictures, skip lesions, and it can involve any part of the intestine. And Crohn's, remember Crohn and cropped. Okay, Crohn, cropped. So cropped, okay, that's the way to remember. There are cropped lesions, they are not continuous like ulcerative colitis. Then the most common genetic cause of liver disease in children is alpha 1 antitrypsin deficiency. This enzyme is usually responsible for inhibiting neutrophil elastase. Okay, neutrophil elastase, this is what it usually does. But when this enzyme is deficient, it can cause uncontrolled activity of this enzyme, and it can damage healthy lungs and liver. Okay, it can damage healthy lungs and liver. That can cause COPD and cirrhosis. Okay, so this is the commonest genetic cause of liver disease in children. Celiac disease, we all know that this is gluten sensitive enteropathy, right? Gluten sensitive. Now you have to do you have to avoid whatever food products can contain uh, gluten, right? So remember this mnemonic: VBOR. VBOR is wheat, barley, oats and rye. Okay, so you have to avoid these things in cases of patients with celiac disease. Enzymes elevated in cholestasis. Enzymes that are elevated in cholestasis patients are, remember this, ANG. Okay, ANG. Now for now you remember this thing. In the next lecture I'll be talking about neonatal cholestasis and cholestasis in children, so that time we can discuss about this or learn more about this. So alkaline phosphatase, 5' nucleotidase and gamma glutamyl transpeptidase. Okay, these are the three enzymes in cholestasis. Again, this is important from the MCQ perspective. HSP, which is basically IgA vasculitis, right? IgA vasculitis. There is a deposition of IgA in the glomerulus and the small vessels of the skin. Okay, deposition of IgA. Most common cause of nephrotic syndrome is minimal change disease. Why it is called minimal change? Because there is little to no change noticed on light microscopy. Okay, but on electron microscopy you can see that there is diffuse effacement, okay, of the podocyte foot processes. Diffuse effacement of the podocyte foot processes. Foot process. Okay, then 39 number question is child with recurrent UTI. Okay, most likely cause is vesicoureteral reflux. Here you can see the 5 grades of VUR. Okay, starting from grade 1 to grade 5, it is in increasing order of severity. Most common cause is VUR, cause of recurrent UTI. Koenig's and Brzezinski sign, this picture is self-explanatory. Okay, we are flexing the hip, flexing the knee and then extending the leg. Okay, this causes pain. This is Koenig's sign. Okay, and Brzezinski sign is when we passively flex the neck, the child will flex the hip and the knees. This is the Brzezinski sign. Most common cause of neonatal meningitis, E. coli, group B streptococci and listeria. Group B streptococci like strep, A. galactiae. Okay, A. galactiae. So remember this, okay, neonatal meningitis, E. coli, GBS and listeria monocytogenes. Most common posterior fossa tumor in children is astrocytoma. And the tumor with the best prognosis is also cerebellar astrocytoma, a brain tumor with the best prognosis. Neural tube defects, we all know that they can be prevented by supplementation of folic acid preconceptually and also preconceptional and as well as after conception for the first during the first trimester. Acquired extracranial infection that causes aqueductal stenosis. Now here you can see there is stenosis of the duct, okay, that is because of mumps infection. So remember this again, this is mumps is because of mumps can cause meningoencephalitis and that can cause acquired aqueductal stenosis. Supratentorial tumor, most common is craniopharyngioma. Okay, now in the sellar region near the pituitary gland, there is, if there is a tumor arising, most common tumor is craniopharyngioma in that region. Okay, and this is from the remnants of the Rathke's pouch. Okay, Rathke's pouch. Usually at around birth it should have disappeared, but sometimes there are some specific mutations which can cause these cells to multiply and form a tumor, which is the craniopharyngioma. Dolichocephaly, this is premature closure of sagittal suture. Okay, sagittal suture, like you can see, this is the sagittal suture, the anterior posterior one. If that fuses prematurely, then you will have the child with an elongated head, which is dolichocephaly or scaphocephaly. Brachycephaly, when there is coronal suture closes prematurely, this one, okay, this sideways, this suture closes prematurely and that can cause flattening of the posterior part of the head and brachycephaly. Port wine stain is seen in Sturge-Weber syndrome. It is basically a capillary hemangioma. Okay, this can occur sporadically also. Okay, usually Sturge-Weber syndrome is associated with a port wine stain on the face, but other syndromes like Klippel-Trenaunay. Okay, so Klippel-Trenaunay, okay, syndrome, this can occur with the same port wine stain on limbs. Okay, so this is associated with Sturge-Weber as well as Klippel-Trenaunay syndrome. Mousy odor of the urine. Mousy odor of the urine is seen in phenylketonuria, and it is because of accumulation or excretion in the urine of phenyl acetic acid. Okay, there is impaired metabolism or improper breakdown of phenylalanine. Okay, and the product that is formed, the phenyl acetic acid, this product causes the mousy odor of the urine. So those are the 50 questions for today, and in the next part we will be seeing another few questions which are commonly asked in NEET PG and other competitive exams.